Now, Professor Gulshanjit Singh is here. Please stand up, sir. He was the professor and head of Safdarjung Medical College. And Venus Association of India, Dr. Rahul Jindal, please stand up. Dr. Dekiwadia, please stand up. So these three gentlemen, and of course I also went there, on one of our conferences in Delhi, we were surprised that nothing was happening. So Professor Gulshanjit Singh, we went there 3 or 4 times, maybe a few more times I think. Successfully started up first foam sclerotherapy, then we did laser, then also we did taught people how to do EVLT. And we were ably supported by that medical and 2 or 3 other compression people, stockings people here. One is circuit people and of course down south from my own Kerala. I won't tell their name because they will come forward. They are here. So we will teach you how to do venous limb ulcer treatment. We will teach you how to do foam sclerotherapy to start with and eventually laser, which is the most common. If you are willing, please let us know, sir. We will come on our own money. We will be with you for a week. And by the end of it, we should be able to help you. But one thing is, we can't go to all the medical colleges all over the place. If one of the government medical colleges is willing to host us, the Venus Association of India will come for you, sir, and for our own people. Ultimately, at the end of the road, our people is what matters. Thank you.
It's my honor to invite Dr. D Dekiwadia, a national figure in vascular surgery and particularly Venous Association of India. He would be talking on management of DVT. Kindly note that's a typographical error on the program sheet. I apologize for that. It's not DVR. He'll be talking on management of DVT.
Morning, friends. It's a pleasure once again to be in Kolkata, once more with the friends. With the final remarks that we saw Dr. Bhattacharya giving and making an instrument. And then we were telling, oh, this is this, good, bad. No, my dear friends, I take it very differently. I was also an associate professor of surgery in a government medical college, Jamnagar, Gujarat. And one of my patients was working in a lignite mine. And people working in the coal mines, this is talking 1981. People working in coal mines, they have to put a helmet and a helmet with a torch, a bulb, so that they can see in that darkness. He presented me one. And our government medical college did not have a very good operating light, and I used to wear this helmet, and my operating field would become wonderful. It's no wonder that 2 Nobel Prize winners are from Bengal. And if you develop these instruments, maybe a 3rd one will be from here. So we have to take it very positively. It's wonderful.
Sir, 4 are from Bengal.
4 are from Bengal, yes. I'm sorry, I stand that correction. Now, deep vein thrombosis. See, so far we've been talking on the superficial veins. So now I want to take you down a little deep in the that Titanic submarine and go into the deep veins. And it's very commonly observed these days, deep veins getting thrombosed. So, how to approach deep vein thrombosis? Let's see what is my journey through deep vein thrombosis. I've been treating since 1986. The initial treatment was venous thrombectomy, like arterial embolectomy or thromboembolectomy. Then there was a heparin treatment and painkillers and leg elevation, compression bandages for the chronic case. But then when we developed our center, we got a vascular cath lab, and then we learned ultrasound. See, ultrasound is the vascular surgeon's stethoscope and a vascular cath lab. When you listen the word cath lab, because you are all growing surgeons, cath lab means, 2-3 crores, corporate hospital, this. No, it's not so. You can have vascular cath labs which are meant for vascular procedures, not for cardiac procedures. And it is here where you can even do lots of other surgical procedures. So we learned ultrasonography, we developed a vascular cath lab, and then we learned more the treatment of DVT. For you, my dear friends, the young generation, you will be facing this in your outdoor. Pain in the calf, true DVT 90%, false DVT 97%. Calf tenderness, see they are similar. A DVT has pain in the calf, tender calf, decrease in skin temperature, unilateral edema, positive, Homan sign, but that is present in false DVT also. So it is here where you have to think of deep vein thrombosis, and when you think of deep vein thrombosis, you will be able to diagnose deep vein thrombosis. In India, 48 out of 10,000, this is the Indian perspective study. And DVT affects lakhs of Indians each year, but very few are diagnosed. Why? That is why they are undiagnosed or underdiagnosed. Low level of understanding about the disease in general population, lack of awareness, and poor knowledge of the disease at tertiary level healthcare. They don't know about DVT, and you don't see what you don't know. That is what is taught in pathology. From 1975, during my undergraduate and then postgraduate and then as assistant professor and so forth, 3 to 4 cases of DVT, they were labeled lymphedema per year. And relatively higher number of patients presented with varicose veins and ulcers. They were secondary to DVT, which is known as post-thrombotic syndrome. But now higher number of patients with DVT and post-thrombotic syndrome both are recognized, and PT has taken a place as a separate entity, post-thrombotic syndrome. For you to diagnose, the young generation to diagnose varicose vein with a swollen leg, almost 1.5 times the opposite one, and ulcer and dark skin. Think of deep vein thrombosis in the past, and these varicose veins need more of understanding, more of evaluation before you touch them with any of the modern devices. Why the rate has increased? What could have happened? Increased awareness, lifestyle modification, modernization in medical science, availability of so many gadgets, better option on treatment modalities, and increase in general population. Our population has also increased. We have a population what we call as outburst. Catheter-directed stomatolysis is a standard method of established proximal DVT. How it is done? It is done by intrathrombus delivery of tissue plasminogen activator called TPA. Dr. Rahul Jindal will be demonstrating the steps one by one soon, I think after about 2 hours in the same session. 2 common types of tissue plasminogen activators are available. One is recombinant RTPA and other is urokinase. My dear friends, all sitting over here, I'll tell you, all of you have suffered from some form of a thrombosis in your body. It's a natural process. A little injury and you get a small thrombus formation in the vein. Even the bruise, what you call, bruise, ecchymosis, these are all thrombi in the small vasculature just below the skin. But in the body, the liver produces urokinase and the thrombus is cleared out in a short while. When the thrombus load is too much, when it is extensive, then you need immediate treatment. Why you need immediate treatment of deep vein thrombosis? It's just because this thrombus can get dislodged, and once something travels in the venous system, it will go and block into the heart. And once it goes and blocks the pulmonary artery, death is guaranteed. In these surgical wards, you must have seen by now at least one patient. Everything was okay. He was doing very well. In the morning, we were to discharge the patient. He went to the toilet and then developed chest pain and he died. And cause of death, myocardial infarction. sudden heart attack, nothing doing. It's all DVT resulting into acute pulmonary embolism and instant death. These are silent DVTs. So this is how we go. You need this cath lab. This is a very modern cath lab, very advanced cath lab, and a proper setup, but this is a setup of these years, recent years. Someday again, I keep on coming here as long as Dr. Mukherjee and Jayanto will keep on calling me, I'll keep on coming here and I'll bring a few slides of the yesteryears. And still we used to do cases. We would have done now more than 900 DVT, 900 thrombolysis. And every year the number keeps on increasing. We do an ultrasound guided puncture, and then we advance a multi-hole catheter, a catheter which has got multiple holes. And you can see this. This is just an example, like a fountain of water. You know, this is how the drug is delivered. And this catheter is inserted either through popliteal vein puncture or posterior tibial vein puncture. Once this catheter is introduced, it is stuck inside the thrombus, like this, very slowly and gently. And then the drug is delivered, like this. And once this is done, it is to be continued for 24 hours. Slowly the thrombus melts. This catheter is very long. This catheter is very long, and it can be parked from the back of the knee, that is popliteal vein, right up to the common iliac vein, that is near the umbilicus. That long catheter with multiple holes, and then you deliver the drug. There are many methods of delivering the drug also. And then the thrombolysis, once it is done, this is what is the result of a thrombolysis when it comes down. And once you have done thrombolysis, this is where the edema comes back. See this? Here you can see the swollen leg, and once thrombolysis is done, you can see the leg coming back to normal. If you do not do this, if this is not done in time, this is what happens. Untreated or poorly treated, long-term is post-thrombotic syndrome. You see veins anywhere and everywhere. You see a swollen leg. You see a darkened, pigmented leg with ulcer. And then you go on treating with various methods of ulcer treatment, ulcer management, biopsies. Dr. Mukherjee enlightened on that very well. How, we keep on facing various challenges. So, and when this happens, there is a reduction in the quality of life. Physical life, social life, psychological life. That goes down. So, this has to be treated. Recently, there has been a change in the thinking pattern in the past decade. I will run over on these very fast. That this is basically an inflammatory process. Like Dr. Bhattacharya said, aseptic inflammation happens. So this is what actually happens. There is an inflammatory change. The role of arterial thrombosis and arterial inflammation is very well understood. But recent studies have shown venous thrombosis due to some inflammatory change, and some inflammatory markers are known. The normal endothelium is vasodilatory and fibrinolytic. Once the endothelial injury occurs, vasoconstriction develops, and once vasoconstriction and inflammation get together, prothrombotic atmosphere is created. And then the thrombation. You see, inflammation is basically a protective mechanism. It eliminates cause of cell injury and vascular changes, influx of inflammatory cells, and widespread effect of inflammatory mediators come in. So when you see a case of deep vein thrombosis, you'll be able to find out a cause somewhere. There could be a cause of injury, fracture, or a cesarean section, or a normal delivery, with some sort of a secondary infection setting in. Or, there was a Mahachandi Yagna suddenly done in the house, 9 hours of sitting squat. And that Maharaj murmuring all those Sanskrit sloks nicely, least understood by him and not at all understood by us, but 9 hours sitting, and you get up, your leg is swollen, DVT. So there are many, many reasons. Inflammation can cause DVT. Here, you can see this is red inflamed. It can cause DVT, and DVT can result in inflammation. This has brought two types of DVT in front of us. One is known as phlegmasia cariola dolans, and another is known as phlegmasia alba dolans. So, alba is where DVT and then inflammation. Cariola is inflammation and then DVT. It is also known as phlegmasia rubra dolans. These are the old terms. Nowadays, these type of poetic terms are becoming less and less. But if you memorize them well, they are stored well in the mind. So that is inflammation. And inflammation can go for resolution or chronicity. And the aim of CDT, catheter-directed thrombolysis, is to reduce the thrombus load, preserve valve, relieve symptoms, and prevent the post-thrombotic syndrome. So, we have to treat this. Ultrasound helps us a lot. Surgery, you are surgeons. Once you do any surgery, fibrinolytic shutdown occurs for a short while. So this you must remember: malignancy, CV catheters, homocystinemia, etc. There are hormonal causes, protein S, protein C, pregnancy related, there are certain genetic causes. These all have to be brought in mind, and this venous compression, May-Turner syndrome, Dr. Das talked about it very well, the compression of the artery. And where does a thrombus start? It usually starts in the cusp of a valve, and then that is where a vis ergo happens. And at the cusp of a valve, there is the least fibrinolytic activity, and a thrombus begins at that place. These are the new regimes, the novel and newer oral anticoagulants. There are roles of cerazopeptidase and even antibiotics. Statins in DVT has also been studied in the Jupiter trial. All these are all related to the inflammatory cycle and thickening of the vessel wall. And our ongoing surveillance says that lesser incidence of PTS after DVT, thrombolysis, catheter-directed thrombolysis, and adding all these medicines. So let us not go too much in all these things. But DVT normally happens in the lower limb because fibrinolytic activity is least in the lower limb. Take home message, my dear friends: resolution of a thrombus is like wound healing. Normal endothelium and endothelial injury, that changes at the entire milieu, interior and prothrombotic atmosphere. The entire thrombus is not of the same age. Gradually it increases. And catheter-directed thrombolysis, the goal is the blocked vein, the opened up vein. Many new devices have come up. Many new devices. They keep on coming up, suction and this and so far. Dr. Jindal will be talking more on this when he goes on to step by step on the DVT. But my dear friends, the first two slides, painful leg, swollen leg, think of a deep vein thrombosis and ask for an ultrasound examination. That is, if you know this much, rest of you can go on and on reading and planning and understanding. And you know the best person to help you in your ward rounds, of course from the boss, from the teacher, we're going to learn. But from the nursing staff who have a look at the leg, because surgeons, they want to first feel the abdomen, less use the stethoscope, and least look at the legs. Make a habit of seeing the legs also regularly. Thank you very much, my dear friends.
Thanks a ton, Dr. Dekiwadia. That was an excellent presentation. With your permission, I'll just, can I share just one sentence to the junior delegates?
Sir.
And it's very common, you're called to see a patient with cellulitis, an acutely swollen lower limb. It's a very humble submission. An acute cellulitis, the limb is always warm. If it is not warm, it is a DVT. 5 out of 50 misdiagnosed cellulitis are actually DVT. Yes. And if they complain of a disproportionate degree of pain, 1 out of the rest 45, please ask for an MRI. It will be necrotizing fasciitis.
Absolutely.
Thank you very much.